thank you for coming, everyone. We have one case today that we will be discussing the immune thrombocytopenia with Dr. Adam Cuker. I'm pleased to have him in our session. Dr. Cuker is an associate professor of medicine and pathology and laboratory medicine at the University of Pennsylvania. He is chief of the section of hematology, director of the Penn Comprehensive Hemophilia and Thrombosis Program, and assistant director of the Penn Specialized Coagulation Laboratory. He conducts patient-oriented research on disorders of hemostasis and thrombosis. So welcome, Dr. Cuker, again.
Great. Thank you so much for having me. Nice to be here.
So we have only one case today, and we will make the case a little bit complicated as we will go through, and we will try to get insights from Dr. Cuker and other attendees if they have any extra comments. So this is a 31-year-old female patient with history of SLE presented to emergency room with petechia, found to have a hemoglobin of 13.8 gram per deciliter, WBC 7, repeated platelet count less than 5 with LDH of 200. She had the regular Hep C HIV coagulation lab that they were all unremarkable with the unremarkable CMP. She was diagnosed with the ITP and started dexamethasone with 40 milligram daily and given the 1 dose of IVIG, 1 gram per kilogram. On the third day, she completed the 2 gram IVIG. On third day of hospitalization, her platelet count recovered to 35, and she discharged home on 2 more days of dexamethasone to follow up with the hematology for further directions. So after 4 weeks that she received dexamethasone and IVIG, her platelet count dropped back to 5. And so the first question to Dr. Cuker is, when do you consider the secondary workup, and what does your workup usually entail?
Yes, thank you. So it certainly appears that this patient has ITP. This is a pretty classic presentation with isolated thrombocytopenia. And because we don't have sort of a gold standard test to diagnose ITP, it is a diagnosis of exclusion. But in my mind, the very best evidence for ITP is a platelet response to treatment. And it sounds like this patient did have a good platelet response to corticosteroids. And so for me, I would be fairly convinced at this point that we have the right diagnosis. This is ITP. So then the question becomes, is this primary ITP or is this secondary ITP? ITP associated with a predisposing condition. And because this patient has a history of lupus, she, by definition, has secondary ITP, ITP secondary to lupus. There are other predisposing conditions associated with secondary ITP that are worth thinking about. I always think about infections like HIV, hepatitis C, and H. pylori. This patient has been tested for HIV and hepatitis C already, and those tests were negative. I typically would not test for H. pylori unless she was having GI symptoms to make me worried about H. pylori, or if she was from a part of the world where H. pylori is endemic, like Latin America or East Asia. Other predisposing conditions, we sometimes see CLL. I don't think there's anything to be especially worried about with CLL here. Broader autoimmune diseases, in this case, we know the patient has lupus, but we also see other autoimmune diseases like antiphospholipid syndrome and ALPS associated with ITP. And then some patients can have immune deficiencies associated with ITP, like common variable immune deficiency or selective IgA deficiency. My personal approach is that I try to do a thorough history, review of systems, physical exam to sort of get at all of those issues. If the patient doesn't have anything on the history or exam to suggest one of these predisposing conditions, my routine is to only test for HIV and hepatitis C because they are common and because their identification would change the way we manage the patient. But apart from those tests, I wouldn't do anything routinely for secondary workup. And again, going back to this case, this patient appears to have secondary ITP due to lupus.
Okay, Great. So when do you repeat the IV? So let's say the patient dropped the platelet count in 4 weeks, and would you consider repeating the IVIG with dexamethasone trial?
Yeah, thanks. I mean, so I guess the fundamentally the question is like, when do you need to use IVIG? Uh, we typically use corticosteroids for rescue therapy. That's our first line rescue therapy. When do we need to add IVIG? And I would say that there are a couple situations where I would do that. I would do that in somebody who presents with um, very severe thrombocytopenia and a high risk of bleeding, or somebody who's having significant bleeding, where there's really a great urgency to get the platelet count up as quickly as possible. In somebody like that, I would add IVIG to steroids. I would also add IVIG in somebody who was not responding to steroids. And of course, I would consider using IVIG in somebody who just was intolerant or unable to receive steroids. In this case, if the patient certainly has a very low platelet count with this relapse, and if she's having bleeding symptoms, I would have a very low threshold for using IVIG. On the other hand, if we can say that this patient's not bleeding much and she responded well to steroids the first time and responded quickly, I might feel comfortable giving her another course of steroids without IVIG. So it wouldn't be wrong to add IVIG in the setting, but I'm not sure that it's crucial.
Okay. So when do you usually give it at let's say the patient responded initially and 2 weeks or 3 weeks later kind of relapse? Would you consider, if you are considering the IVIG, would you consider giving the IVIG, or you will try only dexamethasone? So what's your
Well,
cutoff weeks for IVIG?
yeah, it's not really a number of weeks that's a cutoff for me. I think of steroids and IVIG as rescue therapies only. These are like short-term answers. They're usually not long-term answers. And so what I'm thinking about in this patient who is relapsing after a single course of high dose dexamethasone is really two things. Rescue therapy to bring her platelet count up into a safe range. And then the second thing is to start something that's going like a second line treatment that's going to allow her to be able to maintain a safe platelet count without the need for repeated steroids. That's what I'm thinking in a patient like this. And I think this is a nice case because it speaks to the clinical question we all often face, which is should we use dexamethasone or should we use prednisone? And there are pros and cons to both. I think if you ask a hospitalist, they always prefer dexamethasone because dexamethasone, the one advantage it has over prednisone is it produces a faster response. And the hospitalist's main goal is to produce a fast response and get the patient out of the hospital. But the problem with dexamethasone is exactly what we're seeing here, which is that it's not uncommon for patients to relapse a few weeks after they finish their cycle. And then what do you do? Do you give them another cycle of dexamethasone? What do you do? Do you give them IVIG? That's why control freaks like me and people who tend to take care of patients after they leave the hospital might have a preference for prednisone because prednisone gives you more control. In a situation like this, I would probably be inclined actually to treat this patient with prednisone, and then I would taper hopefully the patient will respond, and I would taper the prednisone gradually as the platelet count allows. And I would think about starting some kind of a second line therapy so that we can safely get the patient off steroids more quickly.
Okay, great. So so let's say the case is the same. The 4 weeks later patient still has a platelet count of 5. So you would consider the second line treatment for this kind of relapse ITP in addition to IVIG, possibly with prednisone with IVIG possibly. So I think we covered this question as well. So let's say you treated patient with dexamethasone IVIG, and the patient 4 weeks later platelet count dropped against the same case, and then you gave the rituximab weekly for 4 weeks. Patient recovered the count, and then 6 months later, patient again presented with the relapse after the rituximab. How would you approach this case?
Yeah, thank you. And this is a pretty great, excellent illustration of, I would say the biggest limitation of rituximab. So among sort of second line therapies, I tend to use rituximab less. And the reason is because of, I would say, the disappointing long-term response rate. So maybe about 60% of patients will have a response to rituximab. Sometimes that response doesn't happen right away. The median time to response is about 6 weeks. Um, but often those responses are not sustained. So by the time you get to like 12 months out, only about 40% of patients who had an initial response are still responding. And so you often need to try to resort to other treatments. And that certainly appears to be the case here. So in this patient who's now relapsed within 6 months after treatment with rituximab, I would not be inclined to use rituximab again. I usually only retreat with rituximab if the patient's prior response lasted at least a year. I would try to look for something that would hopefully provide a more durable response. And in this case, that would most likely be a thrombopoietin receptor agonist.
Okay. And so, is that decision, TPO mimetics versus the rituximab, is also driven by the secondary causes, or would you consider TPO mimetics regardless of the secondary, like in this case, SLE?
Yeah, that's a good question. I might be more inclined toward rituximab if, the patient's rheumatologist said their lupus is not well controlled and they might benefit the, from a lupus perspective from rituximab. Then maybe we can try that and maybe kill two birds with one stone, control their lupus and their ITP. But unless it was a situation like that, um, it the presence of lupus wouldn't influence me. And I certainly have no reservations about using TPO receptor agonists in patients with lupus or other forms of secondary ITP.
Okay. So, let's a little bit complicate the case. When would you consider doing the bone marrow biopsy in this relapse patient?
Yeah, so we don't do many bone marrow biopsies in patients with ITP or in patients in whom we suspect ITP, and that's because bone marrow biopsy is not useful for diagnosing ITP. The purpose of bone marrow biopsy is to rule out an alternative etiology for the patient's thrombocytopenia. So I would say that there are two main situations where I do bone marrow biopsy. One would be at the time of the initial presentation, or I guess anytime during the patient's course, when the patient is presenting with atypical features. So a good example is I remember seeing a patient about 6 months ago who was referred to me for refractory ITP. The patient had been treated with steroids and IVIG and wasn't their platelet count wasn't getting better. And when I looked at their CBC, I noticed that they had a macrocytosis. And that's, of course, not typical of ITP. And they, we ruled out, folate deficiency, B12 deficiency. And the next step was to do a bone marrow because I had doubts based on this atypical feature that this was actually ITP. And indeed, we found out that this patient actually had MTS. Another time that I would consider a bone marrow is when, even if the patient is presenting with clinical features, they are just not responding to treatments in the way that I would expect. Because the fact of the matter is that most patients with ITP respond to treatment. Most of them respond to steroids and IVIG. And so if the patient has shown no response to those treatments, that is enough for me to call into question my diagnosis and do a bone marrow to make sure that I'm not missing anything. Those are the two contexts where I do bone marrow biopsies of these patients. But the truth is that for me, the vast majority of ITP patients I see don't get a bone marrow.
Okay, fair. And then, so a little bit more complicate the case. So, what? Let's say the patient responded to rituximab. Would you consider giving another CD20 monoclonal antibodies, obinutuzumab like?
Yeah, thanks. I mean, I have personally no experience using anti-CD20 and drugs other than rituximab for ITP, but I know that there's literature that they can be used. What I don't know is whether there's any evidence, and I don't think there is, that one will work better than another, that one will, if a patient had a disappointing response to rituximab, that they might have a better, more durable response uh, to obinutuzumab, for example. So I don't think I would do that. The reason I would use a different anti CD20 would be if, for example, somebody had a good response to rituximab, but they had toxicity such that they weren't able to tolerate it with future courses. That's where I would probably consider using an alternative anti CD20 drug.
Okay, great. And then when you said you would consider using the TPO mimetics before or after the rituximab, so can you a little bit elaborate on which mimetics you will start first, or did you consider the splenectomy instead of the TPO mimetics? The third part of that question is, do you consider to discontinue the TPO mimetics on ITP patients?
Yes, yes. Oh, good questions. So we have, the
I mean,
FDA.
it's going to be local control if you're.
Oh, the FDA has approved three different TPO-mimetics for ITP, as you all know. One is romiplastim Nplate, and that's a weekly subcutaneous injection. And then there are two oral drugs. There's eltrombopag or Promacta, and avatrombopag or Doptelet. In my experience, and certainly based on clinical trials, they are all highly effective for treatment of ITP. They are also generally well tolerated. Um, and so in most patients, I'm quite comfortable using any of the three. The only exception might be in somebody with liver disease. I might be inclined to avoid L-trombopag because one of its toxicities, which it does not share with the other TPO-RAs, is that it can cause liver injury. Um, so basically what I do is talk about these three options with the patient. Many patients will prefer an oral agent, but I have had patients tell me they would prefer to get a weekly injection rather than try to remember to take a pill every day. And we talk about, and I sort of help the patient arrive at a decision that's best for them. Sometimes this is also dictated by insurance, and the patient's insurance company will sort of, dictate which of the TPO-RAs we start with. And then if somebody doesn't respond well to one TPO-RA, there's pretty good evidence that they may still respond to another TPO-RA. So, I see these as, being non-mutually exclusive options. If somebody tries L-trombopag and they don't have an adequate response, we could try switching them to avatrombopag or romiplastim. You also asked about do we ever try taking patients off TPO receptor agonists? And the answer is yes, absolutely. There is good evidence that maybe about a quarter or a third of patients who respond to TPO receptor agonists are ultimately able to come off their treatment and maintain a safe hemostatic platelet count off treatment. The way that I do this is, I think, pretty organic. Uh, what we basically do is if a patient is having a robust platelet count, we lower the TPO-RA, typically try to use the lowest dose needed to achieve a platelet count of 50 or higher. And sometimes you get to the very lowest dose and the patient is still having a robust platelet response. And those are the sorts of patients where we discuss stopping the medication. And when we stop it, we initially, of course, monitor the platelet count very closely for relapse. But I have many, many patients in my practice who have been able to safely come off their TPO-RA, some of whom had very refractory disease in the past and had received multiple treatments and long-standing ITP. And some of these patients are still able to come off their treatment and maintain a safe platelet count off treatment, some for years at this point. So that's how I sort of select patients for ultimately stopping a TPO-RA. And then your last question Dr. Bott, was about splenectomy. And, my practice, which is consistent with the ASH guidelines, is to try when possible not to do a splenectomy in the first 12 months after diagnosis. The reason for that is because spontaneous remission of ITP, when it does occur, is most likely to occur in the first 12 months. And it would seem a shame to remove the spleen of somebody who is destined to remit anyway. And so we try to manage patients with medical therapy for at least the first 12 months. But if somebody still needs treatment beyond 12 months, that's when I add back splenectomy as an option to discuss with the patient.
Okay, great. And also, I mean, a little bit hypothetical question, but we know the end plate versus the L-thrombopag acting places TPO on the TPO receptor being outside of the receptor versus the a little bit inner side of the TPO. Do we know anything about avatrombopag? Is that the same place that it acts on the L-thrombopag or different?
Correct. Same as L-thrombopeg. That's correct. And yet there are still patients who seem to respond better to one than another, interestingly. And it's bidirectional. Some respond to one avatrombopeg better, some respond to L-thrombopeg better. So even though they have virtually identical mechanisms of action, it's still worth trying the other one when the first one, when you're not, doesn't provide an adequate response.
Okay, great. And before we will move to the following question, when do you consider doing the accessory spleen workup? Do you consider after the splenectomy being done? And do you usually consider it?
Thanks for the question. Very rarely. So accessory splenectomy is an act of desperation that would only be pursued in somebody with, extremely refractory ITP, where you just can't find good alternatives. And the reason for that is because, it at least in the literature, if you look, it doesn't work very often. There's a lot of evidence that accessory splenectomy doesn't usually help. The sort of patient where I would consider accessory splenectomy would be somebody who, has an initial good response to splenectomy, and then, sometime later has a relapse in their ITP, and we do imaging and we find evidence of an accessory spleen. That's the sort of patient where I might think about doing accessory splenectomy. But again, the evidence for its effectiveness is quite limited.
Okay. I think we can move. So the question is, maybe we answered this. When do you not consider splenectomy? I think you answered this, right? Anything you want to add?
Yeah, I mean, I guess, I think something that you're all probably well aware of is that splenectomy is done much less often now than it once was. And that's probably because we have so many more and so many better medical therapy options than we used to. So there are many patients now who have a strong preference for avoiding splenectomy, and I do my best to honor that. So one of the reasons not to consider splenectomy is because of patient preference. Another reason might be patient comorbidities. Splenectomy can usually now be done laparoscopically and has become quite a safe procedure. But of course, patients with very significant comorbidities are going to be at increased surgical risk. And that's another population where we might prefer alternative treatments to splenectomy.
Okay. So I think we also touch base on this question. So can you also talk about kind of put this case on the side, but how often do you see the drug-induced immune thrombocytopenias in the inpatient setting?
Yeah, sure. So it's not commonly, although it's very commonly invoked. So I think it's important to point out that there are a couple different ways that drugs can induce immune-mediated thrombocytopenia. The usual way is when a patient started a drug, typically a week or two prior to their presentation, And they develop IgG antibodies that depend on the presence of the drug or the drug metabolite to induce thrombocytopenia. And the way you make these patients better is by identifying and stopping the culprit drug. And so when we're thinking about this as an etiology, one of the keys is to look at not drugs that the patient started a day or two before their platelet count fell, but drugs that they started a week or two before their platelet count fell. And this is an error that I see made in the hospital all the time. You've all seen these, been consulted on these patients in the ICU who have developed thrombocytopenia, and one of the considerations is drug-induced thrombocytopenia. And the team says, well, we just started, drug X yesterday, and now their platelet count is low, so maybe it's drug X. That's not a time course that's consistent with drug-induced immune thrombocytopenia. It's to look and see what they started a week or two before the platelet count started to fall. The other mechanism of drug-induced immune thrombocytopenia that we do occasionally see is patients who are treated with a drug that produces a long-term effect on the immune system and can lead to the development of ITP even after the drug has been discontinued. And so we see this with checkpoint inhibitors, for example. We can see this with alemtuzumab, especially when it's used to treat multiple sclerosis. So this is another form of drug-induced ITP.
Okay. Do you do any workup when you are considering the drug-induced thrombocytopenia cases?
Yeah, so there are in the first and more common kind that I mentioned, where the patient started a drug a week or two ago, and now they've developed new onset thrombocytopenia, and I'm suspicious that maybe, for example, the antibiotic that they started a week or two ago is the cause. There is specialized testing that can be done to look and see if that's the case. That testing is not done locally for most of us. It would be a send-out test. And the lab that I'm most familiar with that does this sort of testing is Versity, or the Blood Center of Wisconsin and Milwaukee. So this is, testing that in practice is not ordered that often because, the results take a while to come back and you need to make treatment decisions before you get those lab results. So in reality, what we do is when we suspect a drug, we stop it and see if the platelet count gets better. And we don't usually order the confirmatory lab testing. But there might be special cases where that confirmatory lab testing is useful. For example, when there's a combination of different drugs that could be culprits and you want to try to figure out which one it was, when the patient maybe would have like a strong indication for exposure to a certain drug in the future, and you want to just double check that it's safe for the patient to receive it in the future. But ordinarily we don't order this testing.
Okay. So there are, I listed all of them because neither of them is proceeded yet to FDA approval. But I think it's important to go one by one and get your insights based on the presentation that has been done, or some of them case reports. So how do you consider the refractory cases? When do you consider this maybe compassionate use? So at this point, efgartigimod, sutimlimab, bortezomib, daratumumab, and rilzabrutinib.
Yeah, thank you. So this is an exciting time for ITP. There's a lot of drug development in the space. ITP is getting to be a tough market, and I think that's thanks to the TPO-RAs. They are such an effective and well-tolerated treatment for most patients that it sort of sets a high bar for new drug development for ITP. And I think that the sorts of things that we could look for in new drugs are as you sort of mentioned, treatments that might be effective in the relatively uncommon patient who is refractory to or intolerant of all of the other good treatment options that we have available. And then I think a second therapeutic goal that we haven't fully realized with current treatments is the potential for a cure. So for example, we talked about how some percentage of patients who respond to TPORAs are ultimately able to come off the treatment and maintain a response. But the fact of the matter is that most patients need to stay on those drugs indefinitely. And so apart from splenectomy, wouldn't it be nice if we had medical therapy that was able to induce long-term responses, treatment-free responses, ameliorate the course of the disease, even cure the disease? And I don't think we're there yet, but that's another aspiration for drug development in the ITP space. So I think that these drugs that you have listed here all show promise in terms of um, potential treatments for those refractory patients who are not well served by the options we have now. Efgartigimod is an inhibitor of FCN, the neonatal endothelial receptor, so it lowers IgG antibodies. Um, I have to say that in the efgartigimod clinical trials, the results are not super impressive. The response rates are not particularly high, but there are some minority of patients who will have responses to efgartigimod, so it's a consideration. Uh, Sutimlimab is a complement inhibitor. Many of you know this drug because it's FDA approved for treatment of cold agglutinin disease. It's an inhibitor of C1s. Um, and it showed promise in a small clinical trial. And one of the really cool things about the results in that clinical trial is how quickly it seemed to work in certain patients. In certain patients, there seemed to be a significant rise in their platelet count, literally within hours of starting sutimlimab. And so I could imagine this potentially even playing a role as a rescue therapy in certain patients because of the very fast time to response, especially patients who present, with especially severe presentations or aren't responding to more standard rescue therapies like steroids and IVIG. Um, I personally do not have experience using anti-plasma cell therapies like bortezomib and daratumumab for treatment of ITP, but I do think that they have a certain appeal in this disease, and that appeal is that we know that many patients don't respond to rituximab or don't have durable responses to rituximab, and the thinking is that maybe that's because some of these antiplatelet antibodies are being made by you know long-lived CD20 negative plasma cells, and so there's a rationale to um, treatment with anti-plasma cell therapy. And certainly these treatments have shown promise in case reports in very small case series, but I think that they require systematic investigation and higher quality studies. And then rilzabrutinib is probably the farthest along among the treatments on this list. So rilzabrutinib is, of course, a BTK inhibitor, and it showed promising results in a phase 2 trial that was published in the New England Journal of Medicine a couple years ago. And a phase 3 trial was just completed with rilzabrutinib. And the results haven't been published yet. I think that they're probably going to be presented at a like ASH in December or a meeting in the near future. But I'm not privy to those results. But I've heard that they're promising and could certainly lead to FDA approval of rilzabrutinib for ITP in the near future. And I want to say just another word about rilzabrutinib. It is appealing for the treatment of ITP compared with less specific BTK inhibitors like ibrutinib. So I'm not sure if any of you have used ibrutinib to treat ITP off-label. I have, and I have had success with it. But one of the limitations of ibrutinib is that it has an off-target effect on platelet function. It inhibits the platelet interaction with collagen and leads to platelet dysfunction and the potential for bleeding. And of course, that's of particular concern in patients with ITP. Rilzabrutinib has more specificity for BTK and does not appear to have those off-target effects in terms of platelet function inhibition. And so, in that sense, a more appealing treatment for ITP. So, yeah, I mean, when would I use these treatments or other, what are still investigational therapies? I would use them in particularly in refractory patients who are, again, not responsive to or intolerant of sort of standard second line therapies. Those are the sorts of patients who would be very good candidates for participation in clinical trials.
Okay. Yeah, that's very interesting to hear that rilzabrutinib does not have the off kind of target effect. Okay, so I mean, I did not cover here the vincristine. I just noticed that, as well as the fostamatinib. Do you want to talk a little bit about them? I think, I mean, the vincristine is not for ITP FDA, but fostamatinib is FDA approved. But do you want to elaborate on them as well a little bit?
Yeah, absolutely. So I consider, fostamatinib one of the second line treatments for ITP. Sort of what I see as the standard second line treatment options for ITP include the TPO receptor agonists, rituximab, splenectomy, and fostamatinib. Some people might still consider it more of a third line treatment, but for me, it's moved up into the realm of second line. And its efficacy in ITP is supported by phase 3 clinical trials, so it works in this disease, and it's a nice option to offer patients. You also asked about vincas like vincristine. So rarely do we use vincas for ITP. The one role that I think that they have is, interestingly, as a rescue therapy. So they have been shown to be effective in bringing the platelet count up quickly. In ITP, they tend not to produce sustained responses. Usually, we don't need to use vincas in ITP because we have steroids and IVIG. But over the course of my career, I have had a small number of patients who had, extremely severe thrombocytopenia that did not respond to steroids and IVIG. We could not get their platelet count up to a range where we could even safely discharge them from the hospital. And in those patients, we have used successfully vincas added to these other treatments to help bring up their platelet count. But again, it's generally just a short-term response, and you still need to chase it with something that's going to produce a more durable response.
Okay. Yeah, I mean, we also not really kind of discussed about the combinations, TPO with the anti-CDs, or one of this medication with the combination of the TPO. Maybe audience will ask that question. I think I covered most of the questions. I mean, I did not ask this question, but I think we covered this future trial enrollment. Which medications or what approaches do you think is promising for ITP?
Yeah, I mean, I'd say there are other drugs that are, besides those listed on the previous slide, that are under investigation. I mentioned that one of the unmet needs of ITP treatment right now is that our sort of inability or limited ability to cure the disease with medical therapy or produce long-term treatment-free responses. And so there is drug development in that space. There is a drug called ianalumab, which is a monoclonal antibody that targets the BAFF receptor, and it is being studied in early in the disease course with the hope that perhaps it could ameliorate the long-term course of ITP. And of course, that remains to be seen. So that's another example of an investigational agent for this disease. And then the other thing that you asked about or just mentioned, Dr. Bat, was combination therapy. And I think that's a really great question, because the paradigm for treating ITP right now is trial and error and sequential monotherapy. And I am hoping that someday we will get to a better place than that. with trial and error, I mean, we have our favorite treatment and we try it, and if it doesn't work, we move on to the next. Wouldn't it be great if we had some sort of biomarker panel that told us which treatment the patient was most likely to respond to and tolerate well? And I hope that someday in the future we'll have that, especially as our list of treatment options grows. It would be wonderful if we can go right to the most effective treatment instead of having to march through our list for every patient. And then the other, again, paradigm is really sequential monotherapy. The question is, when do we use combination therapy? And combination therapy is not used a lot in clinical practice. I would say that the context where it is used most is in highly refractory patients, where we think that there may be a synergy between different treatments. So, for example, we might combine a TPO receptor agonist, which of course works by stimulating platelet production, with an immunomodulatory drug. So an example might be, I have a patient right now with very refractory disease who is on avatrombopag and MMF at the same time and is responding well to that combination, whereas she didn't respond well to any of the individual treatments. But another place where combination therapy has been explored but is not commonly used is with upfront treatment. So you may know that there are clinical trials where if sort of very intensive combination therapy is used up front, the hypothesis may be we can improve remission rates at 6 months, 12 months, or even cure patients. So the idea of using rituximab and high-dose dexamethasone up front instead of just steroids up front, or a TPO-RA up front. These are all things that have been explored in clinical trials, but haven't really been incorporated into clinical practice. And I still don't think we have a full understanding of whether early combination therapy can cure patients or not.
Yeah, I think I agree with that possible biomarker to decide what to use, right? Because we have so many
So many.
and maybe combinations. I think Dr. Hoffman has a question.
Yes, I was wondering if you could comment on whether your approach to patients who've been treated with immune checkpoint inhibitors, and ITP, or perhaps even lupus or T cell or LGL patients.
Yes, thank you. So I can say I use the same, generally the same kinds of treatments, the same approach as I would with primary ITP to treat somebody with lupus, ITP secondary to lupus, with again that one caveat that if the rheumatologist said this patient's lupus might really benefit from rituximab, maybe that might sway me. And then and the same goes for checkpoint inhibitor induced ITP. We typically treat them with the standard therapies, and there's some evidence that most of them tend to respond to the standard therapies. Maybe someday we'll discover, much like the biomarker panel that I mentioned, that patients with certain predisposing conditions tend to respond better to one drug or another, but we don't have that sort of granular evidence at this point.
Does the time course of response does that differ, do you think, or do we have any evidence, any data as far as little long term? Do they tend to get better quicker? And what do you tend to advise in terms of the future treatment?
Yeah. And is that specifically related to patients with checkpoint inhibitor?
Yeah.
Sophia?
That's what I would be asking about. Mm-hmm.
Yeah. There's not a lot, but there are some case series published on these patients. It's still a relatively new toxicity and new disease for us, and we still have a lot more to learn about it. I have seen in my small number of patients that I've seen with checkpoint inhibitor associated ITP, I personally have seen it a wide variety of presentations. I have seen patients who had, very severe ITP responded well to steroids and it never came back. And then I have seen patients with very refractory ITP who needed multiple treatments, multiple lines of therapy, combination therapies to try to get them into a place with a safe platelet count. So I'm not, at least I'm personally not able, based on my experience, to sort of make any general comments about the course of this condition. There may be people who have more experience than me that can, but I'm not able to.
Right, thank you.
Okay, great. Thank you, Dr. Cuker. This was very helpful. I mean, I hope everybody enjoyed and learned. And we will also posting this on our social media for future use for any trainees, any people, any person to learn about and get your insight. Thank you again, Dr. Cuker.
Thank you so
And I
much for the
hope
invitation.
everybody enjoyed.
It's my
Thank
pleasure.
you.
Have a nice day,
Thank
everybody.
you.
Bye-bye.
Bye.
Bye-bye.